Hello. Okay, so let's talk about structural problems. I just finished talking a lot about heart failure itself. Let's talk about the structure and how the structure, other than just the ventricular muscles, can impact oxygenation and perfusion. So I'm going to share my screen. There we go. Lovely diagram from Mayo Clinic EDU. Thank you very much about the structure of the heart. So basically the next few slides from here on are about valvular heart disease or valve failure, which is a different chapter in Lewis than what heart failure is. Valvular heart disease, there's different types of valve disease, and it's defined according to two things: the valve affected and the type of dysfunction. So the valves affected, mitral, tricuspid, aortic, and or pulmonic. And then there's two different types of problems. You can have dysfunction rather. You can have stenosis, or you can have regurgitation. Stenosis is, instead of having a nice big wide opening, you have a smaller, constricted, more narrow opening. And that impedes the flow of blood going forward. And then you'll have pressure differences on both sides of that valve. Regurgitation is when that valve closes, it doesn't close all the way. Instead of closing all the way and like being tight shut, it just doesn't quite get there. And so because of that, the flow goes back and forth through that valvular opening rather than just like the valve closed. So there's no way other to go than forward. So I've got pictures on the next slide. So if we look here on A, we have a normal valve that's open. We have a normal valve that's closed. If we look at B, there is a stenosis in here. So the valve in the stenosis, this is when it's open. It looks a heck of a lot like it's closed. There is just not a whole lot of opening at all. On a regurg situation, what happens, this is what the valve looks like when it's closed instead of over here in A. So in both situations, blood flow is impeded. So what do we do about that? Let's look at some interprofessional care. There are some conservative therapies, and it's depending upon that, which depends upon the valve involved and how bad the problem is. So basically what we're trying to do with conservative therapy is prevent any exacerbations of heart failure, one of them being pulmonary edema. We're also preventing thromboembolism. If you're not able to have blood flow through the right way, it's either backflowing on push, or it's just not able to get out through the valve, you have a risk of developing an emboli. And then that embolism travels. And then reduced recurrent right failure and IE. Prophylactic antibiotic therapy to prevent those RF and IE, and then a sodium restriction. We do use some different drugs to help control heart failure. We use vasodilators, and we talked about these in the heart failure chapter too. So rather than, these drugs don't necessarily impact the valve, but they're impacting the heart failure that's caused by the valve failure. Vasodilators, positive inotropes like digoxin, diuretics, beta blockers. We'll also have these people on anticoagulation therapy. Again, pooling blood that's not moving the right way has a tendency to develop into emboli, and then those emboli travel and make big problems. As well as, because there is some heart failure with this, because the blood flow is poop, we'll have some antidysrhythmic drugs perhaps associated with this particular population as well. In addition to that, let's say we have a stenosis situation. We can actually go in and use a balloon in the cath lab, and we can those balloons go, oh, and actually it works for stenosis and it works for regurg too. I shouldn't just say stenosis. So what we do is we start in the femoral artery, way down in the hip groin area, and we move it all the way up into the heart. And we come at it, if we do a femoral approach, we'll come at the left side of the heart. If we use an arterial approach, we'll come and do the left side of the heart. If we use a venous approach, we'll do the right side of the heart. And what we do is we use this little balloon that you see here. And this balloon that we see here gets, no, come on. The balloon that we see here, what happens is this is actually in that valve. And then you can see that valve trying to close around the balloon, and it kind of knocks the stuff up. And so hopefully that balloon tipped catheter in the femoral artery will be inflated and separate those valve leaflets and kind of knock whatever junk off of them so that they can open and close properly. In essence, that is what happens when we do a balloon therapy. We can also do surgical therapy, and surgical therapy is, we can do a valve repair by doing open heart surgery. And so I know that when we were talking about coronary artery disease, we talked about people getting cabbages where they're getting bypass grafts. The prep for this is the same. A lot of this is the same, but instead of doing bypass grafts, we're actually fixing the valves. We can either do valve repair, which we're not actually putting anything new in. We're not taking anything out. We're just actually fixing what's there, fixing what's broke in. And so we have a lower operative mortality rate. People are more likely to survive this particular surgery. It's actually preferred for that reason. It doesn't totally restore valve function, but it has better survivability rate than doing a valve replacement. But we can also do a valve replacement surgery as well, where we actually will either use a donated valve, or we can use a mechanical valve. So this figure, number 3611 from Lewis, is 4 different types of mechanical valves. They're artificial. They're made out of, as you can see, metal, plastic, silicone. They are more durable. They last longer, but they have a higher risk of embolism because the body's going to be like, stranger danger, I need to cut you off because you are not natural to me. And then they require long-term anticoagulation because stranger danger, you are not natural to me and I need to clot you off. Biologic ones, you don't have to necessarily have anticoagulation. You can have bovine, porcine, or human valves put into that heart to be able to have a better heart function with that valve closure. Those biologic ones are less durable and they need to be replaced more often than what the mechanical ones do. This is not a decision that we are necessarily a part of. We are part of the post-operative and pre-operative care, and perhaps part of the OR team. We are not helping anybody pick out valves. The other thing that you can do is in the cath lab, you can do a transcatheter aortic valve replacement, which means that we are floating through that femoral artery, all the way up through the aorta, through the arch, and we're going to float a new aortic valve right on top of the old one. It's for severe aortic stenosis. And there's 2 different kinds. There's Edwards makes one called the Sapien 3. Core Valve makes one as well. But this particular picture is why this is here. This particular picture, I think, shows an Edwards Sapien 3. But what happened to be able to have this is they are in the cath lab. The cath lab, the interventional cardiologist has threaded a catheter all the way up here. Give me my pen. And they have threaded a catheter all the way up here that has this little ring guy that you see here. They deploy that ring guy on top of the existing or within that aortic valve space. And so now they have an artificial valve there without removing the old aortic valve. And here I'm going to break this up, and I'm going to break this up into two pieces. So this was interprofessional care. I'm going to pause the recording and then I'll do nursing care. So the next set of slides here will be about valvular nursing management.